morning, everyone. Myself, Dr. Sunil Ninama. I'm Associate Professor from UN Mehta Institute of Cardiology and Research Center. Today, my talk on different modes of ventilations. We'll start. What is the ventilations? Mechanical ventilation is the ventilation of the lungs by artificial means, usually by ventilators. And a ventilator, what the ventilator do? The ventilator delivers gas to the lungs with either negative or positive pressures. My objectives of this is the spontaneous versus mechanical ventilations, non-invasive versus invasive mechanical ventilations, indications and contraindications, and be familiar with the normal parameters of the ventilations, and overview of the modes of ventilations. Discuss the indications of weaning and extubation. What do you mean by spontaneous versus mechanical ventilations? Spontaneous respiration, that means it's a natural breath in which there is a negative inspiratory force inside the lungs which cause, or in the thoracic cavity, which causes the air pulled into the lungs. That's why it's a spontaneous inspirations. And mechanical ventilation, what it does, it's cause positive inspiratory pressures given by the ventilator which causes air pushes into the lungs. What do you mean by non-invasive ventilation versus invasive mechanical ventilations? Non-invasive mechanical ventilations gives the provided by the tight-fitting face mask, and you give the mechanical ventilations. Why? Invasive mechanical ventilations, it provided by the laryngeal mask, endotracheal tubes, or tracheostomy tubes. By a tight-fitting face mask, you can deliver the BiPAP as well as CPAP. What is the indications of mechanical ventilations? That is the respiratory failures, cardiopulmonary arrest, trauma events, cardiovascular impairment, neurological impairment, pulmonary impairment, procedures requiring sedation and paralysis. Criteria for institution of ventilatory supports. In which patients you want to keep the patient on ventilators? So these are the parameters you have to look. First, by pulmonary functions, by examining the patients. If the patient's respiratory rate is very high, is more than 35, then it needs mechanical ventilations. When the tidal volume is very less, by seeing that the patient is not taking enough tidal volume, if the tidal volume is less than 5 ml per kg, then that patient requires mechanical ventilations. Vital capacity, again less than 15, and maximum inspiratory force is less than -20. You have to see the criteria for institution of ventilatory supports by looking at ABG. If the pH of this patient is less than 7.25, if the PO2 is less than 60 and PaCO2 is more than 50, then this patient requires some mechanical ventilatory supports. This is the principles of mechanical ventilations. This is the endotracheal tube, ventilator tubings, major airways, and this is the alveoli. In alveoli, there is a volume and lung compliance. You have to look for that. And in upper airway or tubings to upper airway, bronchus, you have to see the flow and resistance. Principles of mechanical ventilations. Mechanically ventilated patient usually receives the positive and expiratory pressures to overcome the loss of physiological PEEP provided by the larynx and vocal cord. Okay, so that's why this patient require minimum of PEEP at least 5. PEEP is delivered throughout the respiratory cycle and is synonymous to the CPAP. Standard PEEP setting is around 5 cm of H2, and sedation is often required to prevent the ventilator-patient asynchrony. Type of mechanical ventilators are the two types of mechanical ventilators, negative pressure ventilators or positive pressure ventilators. What do you mean by the negative pressure ventilators? In early negative pressure ventilators were known as iron lung and chest cell. The patient's body was encased in an iron cylinder and negative pressure was generated in this cylinder. That's why the tidal volume is delivered by the negative pressure ventilator is directly related to the negative pressure gradient. Intermittent short-term negative pressure ventilation is sometimes used in patients with the chronic disease, and the use of negative pressure ventilator is restricted in clinical practice, however, because they limit the positioning and movement and they lack the adaptability to large or small body torsades. Our focus will be on the positive pressure ventilators. Positive pressure ventilators are the positive pressure ventilators deliver the gas to the patients under the positive pressures during the inspiratory phase. The types of the positive pressure ventilators are the volume ventilators, pressure ventilators, and high frequency ventilators. What do you mean by ventilator mode? The way the machine ventilates the patient and how much the patient will participate in his own ventilatory pattern. Again, each mode is different in determining how much work of breathing the patient has to do. Standard ventilatory settings. If you want to know how to set the ventilator, then this is the synonyms called MORITE. M for mode of, you have to set mode of ventilator. O for how much FiO2 you have to set. R for respiratory rate, which is around 12 to 16. Oxygen FiO2 is around 30 to 100%. Mode, control mode or whatever mode, you have to set. Inspiratory actions to set the tidal volume around 6 to 10 ml per kg. Inspiratory time, you have to set the I ratio 1 gem 1.5 or 1 gem 2. And expiratory action, you have to set the PEEP around 5 to 10. 5 PEEP is normal. Be aware, the positive airway pressures should not be more than 35 centimeter of H2O. Common ventilatory settings, we are looking in this detail, that is the FiO2, tidal volume, respiratory rate, flow rate, minute volume and I ratio. What do you mean by FiO2? The percentage of oxygen concentration that the patient is receiving from the ventilator. You have to set the FiO2 around 21 to 100%. Initially, the patient is placed on a high levels of FiO2 and around 100%. Then gradually you have to decrease according to your ABGs. Subsequently, the changes in FiO2 are based on your ABG or SO2. And FiO2 of 100% at extended period of time can be dangerous, but it can protect against hypoxemia. For infants or children, especially in the premature infants, high levels of FiO2 should be avoided because it may cause oxygen toxicity. That's why it is avoided. What is tidal volume? The volume of air delivered to the patient during a ventilator breath. The amount of air inspired or expired with each breath. Usually the volume selected, that how much tidal volume you have to keep in that patient is around 5 to 15 ml per kg of body weight. In the volume ventilators, the tidal volume is around 10 to 15 ml per kg of the body weight, what traditionally used. The large tidal volume may lead to the volume trauma. So you have to keep around 6 to 8 ml per kg is enough for the patients, around a maximum up to 10 ml per kg. For these reasons, lower tidal volumes we are using. Peak flow rate and flow rate. The speed of delivering the air per unit of time and is expressed in liters per minute is called peak flow rate. The higher the flow rate, the faster the peak airway pressure is reached and the shorter the inspirations, and lower the flow rate, longer the inspirations. You have to set the respiratory rate. The number of breaths the ventilator will deliver per minute is called respiratory rate, and you have to set around 10 to 16 breaths per minute. Total respiratory rate is around patient rate plus ventilatory rate. It is called total respiratory rate. So you have to look for this total respiratory rate. The nurse double checks the functioning of ventilator by observing the patient's respiratory rate. If the patient is awake, patient will come out from the anesthesia, you have to watch for the respiratory rate. Minute volume. What do you mean by minute volume? The volume of expired air in 1 minute is called minute volume. The respiratory rate into tidal volume is called minute volume or minute ventilations. In special cases, hypoventilation or hyperventilation is desired. Now the I ratio, inspiratory time or expiratory time. You always know these things. Okay, I ratio, the inspiratory time and I ratio is around 1 gem 2. What do we mean by the 1 gem 2? The inspiration time is little bit of shorter as compared to the expiratory time, and expiratory time is always prolonged, is around 1 gem 2. It can be reversed. It may be 1 gem 1 or maybe 2 gem 1 in some conditions, like you have to recruit the lung, you have to give the some, if the PO2 is very low, so the inverse ratio ventilations. Some machines automatically alter the I ratio when you have to set the respiratory rate, automatically the I ratio is changed. What do you mean by reverse I ratio? The advantages of reverse, that I ratio means that the inspiration time is prolonged and expiration time is shorter. The advantages of reversing the I ratio is alveolar recruitment, reduce the alveolar collapse due to shorter expiratory time, increase the mean airway pressure without increasing the positive airway pressures. And disadvantages is that air trapping from the increased intrathoracic pressures, hypercapnia, breath stacking, extreme discomfort for the patient and reduction in the cardiac output. What do we mean by shy? A deep breath, a breath that has a greater volume than the tidal volume. It provides hyperinflation and prevents the atelectasis. Shy volume is around 1.5 to 2 times of the tidal volume, and shy rate is around usually the 4 to 8 times an hour. What do you mean by autopip? Autopip is a positive and expiratory pressure caused by progressive accumulation of air due to incomplete expiration prior to the initiation of next breath. That's why there is a air trapping occur and it is called autopip. Peak airway pressures. In adults, if the peak airway pressures is persistently above 45 cm of H2O, then there is a risk of barotrauma. So you have always look for airway pressures in the ventilatory modes. And in infant and children, it is unclear that the level of peak pressure may cause damage. So in general, keeping the peak pressure below the 30 is desirable. Sensitivity, trigger sensitivity. You have to look for the trigger sensitivity on the when you set the ventilators. The sensitivity functions controls the amount of patient's effort needed to initiate an inspiration. When you increase the sensitivity, requiring less negative force, decrease the amount of work of patient must to initiate the ventilator breath, and decrease sensitivity increases the amount of negative pressure that the patient needs to initiate the inspiration and increase the work of breathing. So what do you mean by that? When you decrease the sensitivity, the patient starts breathing, and you have to give the trial for breathing itself. And when you increase the sensitivity, and you don't want to allow the patient to respirate spontaneous breath, so you have to increase the sensitivity. Inspiration, the trigger, you have to set the triggers are different triggers, that is a flow trigger, pressure triggers, and time triggers. What do you mean by flow trigger? A breath is generated when the patient's respiratory effort causes flow to reach at set level. The pressure trigger, a breath is generated by the measuring pressure and starting assisted ventilation when the pressure reaches a given level. Time trigger, a breath is generated by the measuring frequency of the respiration and starting ventilation when respiratory frequency is at given. Expiration is again time cycle, flow cycle, and volume cycles. Modes of ventilators. Now there is a two modes, that is the volume modes and pressure modes. A volume modes may be a control modes, maybe assist control modes, or maybe SIMV, synchronized intermittent mandatory ventilations. We are going into the details of these volume modes. Volume modes. Now when you keep the patient on volume modes, volume ventilations, so what you have to set on the ventilators, it is a volume, it is a tidal volume. You have to set the PEEP, you have to set the rate, you have to set the inspiratory time, and you have to set the FiO2. And what ventilator determines is a pressure required. What pressure required for that volume? Advantages is guaranteed minute ventilations and more comfortable for the patients. And drawbacks is a large endotracheal tube leak and no optimal for poorly compliant lungs. What do you mean by the controlled mandatory ventilation? This is called CMV. In CMV mode ventilator delivers a preset tidal volume and preset respiratory rate. So control mode. This is a totally control mode. So when you keep the patient on control mode, should only use when the patient is properly sedated and you have to give the muscle relaxation to this patient. In classic control modes, patients were unable to breathe except at a controlled set rate. Indication for this, patients fighting and bucking, tetanus, and in patient with the complete rest for at least for 24 hours and crushed chest injury. Complication for that is apnea and hypoxia if the ventilator is disconnected. This is the diagram showing the control mode, control mandatory ventilations. You have to see that is a mechanical breath given for this patient, and there is a no spontaneous inspiratory effort. So this patient is completely sedated and muscle relaxed. Now there is assist control mode. In assist control mode, the name suggests the ventilatory mode is assist the patient. What I mean the ventilatory mode, you have to set the preset tidal volume at a preset respiratory rate. Mechanical breath is either patient triggered by patient's spontaneous inspiratory effort when patient try to breathe. And in this mode, what happen? When patient try to breathe, they'll assist that ventilation and give the preset tidal volume and preset rate. So it is time triggered also. The patient may initiate a breath is own, but ventilator assists by delivering a specific tidal volume to the patient. Client can initiate the breath that are delivered at a preset tidal volume, and client can breathe at higher rate than the preset number of breaths. The total respiratory rate is determined by the number of spontaneous inspiration initiated by the patient plus number of the breaths set on the ventilator. In assist control mode, the mandatory or control rate is selected. If the patient wishes to breathe faster, he or she can trigger the ventilator and receives the full volume breath, often used as an initial mode of ventilation, and when the patient is too weak to perform work of breathing when emerging from the anesthesia. Disadvantages are hyperventilation. This is the assist control. You have to see in the figure, these are the mechanical breaths, and when you have to see that this is a negative inflection which shows the patient try to breathe, and this assist control mode, they assist the total mechanical breath to their patients. Intermittent mandatory ventilations. Intermittent mandatory ventilation is a mode in which the ventilator delivers the mandatory control breath and allows the patient to breathe at any tidal volumes. The patient is capable of in between the mandatory breaths. The intermittent mandatory ventilation is a mode that allows the patient to breathe spontaneously. What do you mean by that? When patient try to breathe in between, he can breathe in between, and ventilator, you have to set the tidal volume and rate. Patient's tidal volume is given at the fixed respiratory rate and fixed tidal volume. So what have complications? Breath taking is happen in intermittent mandatory ventilations. This is the mode of called synchronized intermittent mandatory ventilations. The ventilator provides the patient with the preset number of breaths per minute and specified tidal volume and FiO2. So you have to set the tidal volume, respiratory rate and FiO2. The name it suggests synchronized intermittent mandatory ventilations. What happens in this? In between the ventilator breaths, patient is able to breathe spontaneously at his own tidal volume and rate with no assistance from the ventilator. So these are the spontaneous breathing trials, and when the ventilator synchronizes with the patient's spontaneous ventilations, and it gives the SIMV mechanical breaths. Adding the pressure support to the spontaneous breath can minimize the risk of increasing the work of breathing. So you have to set the pressure support also. Ventilators breaths are synchronized with the patient's spontaneous breath, so there is a no fighting used to wean the patient from the mechanical ventilators. Weaning is accomplished by gradually lowering the set rate and allowing the patient to assume the more work. Maintains the respiratory muscle strength and reduce the ventilation perfusion mismatch. These are the pressure modes now. The pressure modes are the pressure control ventilation, pressure support ventilation, continuous positive airway pressures, positive and expiratory pressures, and non-invasive BiPAP. What do you mean by BiPAP? Is bi-level positive airway pressure ventilations. Now in pressure ventilation, you have to set P inspiratory pressures, you have to set the PEEP, you have to set rate, I ratio, and FiO2, and what ventilator determines the exhaled tidal volume. Advantages provides more support at lower positive airway pressure for P inspiratory pressures for poorly compliant lung, and drawback is minute ventilation is not guaranteed. How much minute ventilation you delivered that patient. This is called pressure control ventilations. It means PCV mode. The PCV mode is used if the compliance of the lung is decreased and risk of barotrauma is very high. It is used when the patient has a persistent oxygenation problem despite of high FiO2 and high level of PEEP. Then you use this pressure control ventilations. In this, the inspiratory pressure levels, respiratory rate, and inspiratory I ratio must be selected. In pressure control ventilation, the breathing gas flow under the constant pressure into the lung during the selected inspiratory time. The flow is highest at the beginning of the inspiration when the volume is lowest in the lung. Once the inspiration begins, a plateau pressure is created and maintains for a preset inspiratory time. The pressure control can minimize the peak inspiratory pressure while still maintaining the adequate oxygenation and ventilation. Advantages of pressure limitations are reduce the peak pressures, therefore the risk of barotrauma and tracheal injuries are very less. Effective ventilations improve the gas exchange, and it is used in the case of ARDS. So when the patient, you have to know that patient is on patient developing ARDS, so you have to keep this patient on ARDS mode, on pressure control ventilation. In this pressure control ventilation, the tidal volume varies with the compliance and the airway resistance and must be closed monitored. Sedation and the use of neuromuscular blocking agents are frequently indicated because any patient ventilator asynchrony usually result in profound drop in SaO2. This is especially true when inverse ratio are used. The unnatural feeling of this mode often requires the muscle relaxation to ensure the patient ventilator synchrony. As the expiration time is decreased, one must monitor for the development of hyperinflation or autopip in case of inverse ratio ventilations, and the regional alveolar overdistension and barotrauma may occur owing to excessive total PIP. When the pressure control ventilation mode is used, the mean airway pressure and the intrathoracic pressure rises, potentially resulting into decrease in the cardiac output and oxygen delivery. Therefore, the patient's hemodynamic status must be monitored closely, used to limit the plateau pressure that can cause barotrauma and severe ARDS. So you have to in this mode, you always set you have to look for the plateau pressures also. Pressure support ventilations. The patients breathe spontaneously while ventilator applies a predetermined amount of positive pressures to the airway upon the inspiration. Pressure support ventilation supplies a preset pressure support ventilation applies a preset plateau pressure to the patient's airway for a duration of spontaneous breath. The pressure support ventilation augments the patient's spontaneous breath with the positive pressure boost during the inspiration. Assist each spontaneous inspiration, so decrease the spontaneous respiratory rate. Helps to overcome airway resistance and reducing the work of breathing. Indicated for the patient with the small spontaneous tidal volume and difficult to wean the patients. Pressure support ventilation may be combined with the other modes such as the SIMV or used alone for spontaneously breathing patients. In pressure support ventilation mode, the inspired tidal volume and respiratory rate must be monitored closely to detect the changes in the lung compliance. It is the mode used primarily for weaning from the mechanical ventilations. These are the pressure support ventilation. You have to see the graph of this. What is continuous positive airway pressure? The constant, its name it suggests continuous positive airway pressures. What do you mean by? That is a constant positive airway pressures during the spontaneous breathing. The PEEP applied to the airway of a patient who is breathing spontaneously. This is a spontaneous breathing plus PEEP. The CPAP allows the nurse to observe ability of the patient to breathe spontaneously while still on the ventilator. CPAP can be used for intubated and non-intubated patients. It may be used as a weaning mode and for a nocturnal ventilations, nasal CPAP. There is a PEEP, positive and expiratory pressures. These are PEEP, positive pressures applied at the end of expiration during the mandatory and ventilatory breath, and positive and expiratory pressure with the positive pressures in the machines. Uses of CPAP and PEEP, it prevents the atelectasis and collapse of alveoli, treat the atelectasis or collapse of the alveoli, and improves the gas exchange and oxygenation, treat the hypoxemia refractory to the oxygen therapy, and treat the pulmonary edema. What do you mean by BiPAP? Bi-level positive airway pressures. It provides you have to set a P inspiratory and you have to set the respiratory rate. Patient can breathe in between mandatory ventilations. Spontaneous breaths are supported with the pressure support, and patient can breathe at any point of respiratory cycles, not just between the breaths. Breathing takes between the two levels P inspiratory and PEEP. Now there is a newer modes of ventilators. There are volume assured pressure ventilations, volume support ventilations, pressure regulated volume control, it's called PRVC, adaptive support ventilation is called ASV, MMV, mandatory minute ventilations, proportional assist ventilations, and APRV is airway pressure release ventilations. We are going little bit of detail in this. There is a volume assured pressure support, a mode of ventilation that assures the stable tidal volume by incorporating in the inspiratory pressure support with the conventional volume assisted ventilations. It provides a stable tidal volume in patients with the irregular breathing pattern. The respiratory therapies have to set the pressure limit or plateau pressure seen during the volume vital capacity, the respiratory rate, and the peak flow rate, and PEEP, FiO2, trigger sensitivity, and minute tidal volume. Volume support ventilations entirely a spontaneous mode. In volume support, clinician sets the target tidal volume and a ventilator used variable pressure support level to provide a target tidal volume used for a patient ready to be weaned from the ventilator and for the patients who are breathing spontaneously. The indication for that is the spontaneously breathing patient who requires minimum tidal volume, patient who have inspiratory effort, who need adaptive support, patient who are asynchronous with the ventilator, or used for the patient who are ready to wean from the ventilator. This is called PRVC mode, a control mode which delivers a set tidal volume with each breath at a lowest possible peak pressures. So it's called PRVC mode, and it is indicated in patient who requires a lowest possible pressure and a guaranteed consistent tidal volume. It is used in ALI, acute lung injury, or ARDS, and patient requiring high and or variable tidal volume consistently with the compliance of the lung. There is adaptive support ventilations, a mode of ventilation that changes the number of mandatory breath and pressure support level according to the patient's breathing pattern. It automatically adapts to the patient's demand by increasing or decreasing the support depending on the patient's elastic and resistance load. The clinician enters the patient's body weight and present minute volume, which allows the ventilator to algorithm to choose a required minute ventilations. So ventilator then delivers to 100 ml per kg per minute. If no spontaneous effort occurs, the ventilator determines the appropriate respiratory rate, tidal volume, and pressure limit delivered for the mandatory breaths. That is a mandatory minute ventilation MMV mode. In this, there is a minimum minute ventilation or augmented minute ventilation. Operator have to set the minimum tidal volume, which is usually expired tidal volume, which is usually 70% to 90% of the patient's current expired tidal volume. The ventilator provides whatever part of expired tidal volume and the patient is unable to accomplish. This accomplishes by increasing the breath rate or preset pressure. It is the form of pressure support ventilation where the pressure support level is not set but rather variable according to the patient's need. Proportional assist ventilation, the operator sets the ventilator's volumes and flow assist at approximately 80% of the patient's elasticity and resistance. The ventilator then generates the proportional flow and volume assist to augment the patient's own effort. Proportional assist ventilations indications are the patients who have work of breathing problems associated with the worsening lung characteristics, asynchronous patients who are stable and have an inspiratory effort, ventilator dependent patients with the COPD. Airway pressure release ventilations, APRVC mode, we have set this APRVC mode is a bilevel form of ventilation with a sudden short release in pressure to rapidly reduce the FRC, functional residual capacity, and allow for the ventilation. Can work in spontaneous or apneic patients. APRV is similar but utilize a very short expiratory time for a pressure release, and the short time at low pressure allows for the ventilations. APRV always implies an inverse ratio, I ratio, and all spontaneous breath is done at the upper pressure level. The indications for that APRVC mode is the partial or full ventilatory supports, patient with acute lung injury, ARDS, patient with the refractory hypoxemia or collapse alveoli, patient with the massive atelectasis, or may use with the mild or no lung disease. Inverse ratio ventilations. In this, the ratio of inspiratory time to expiratory time is known as the IE ratio. Normally, the inspiratory time is lower than the expiratory time. We already discussed these things. I ratio, normal ranges is 1 gem 1.5 to 1 gem 3. Extending inspiratory time during the mechanical ventilation to promote oxygenation in patients with the ARDS. I ratio is used in between the 2 gem 1 to 4 gem 1, and often it is used in conjunction with the pressure control ventilations. And this inverse ratio ventilations, it improves the oxygenation by decreasing the intrapulmonary shunting, increase the vacuum matching, and decreasing the day space ventilations. Patient requires the sedation and relaxation. Now, when your patient on ventilator, you have to give the patient the humidifications. Why? Because all air delivered by the ventilator passes through the water in humidifier where it is warm and saturated. The humidified temperature should be kept closely around to the body temperatures. In some rare instances, severe hypothermia, the air temperature can be increased. The humidifier should be checked for adequate water levels. An empty humidifier contributes to the dry air and often with the resultant with what it causes, it's called dry up all the secretion into the bronchus as well as in the lungs and mucus plugging and less ability to remove that secretions. The humidifier should not be overfilled as it may increase the circuit resistance and interference with the spontaneous breathing. As the air passes through the ventilator to the patient, the water condenses in the corrugated tubing and the moisture is considered contaminated and must be drained into the receptacles and not back into the sterile humidifier. So it may cause the resistance to the patient, resistance to the circuit, and it is cause some flickering into the circuits. By that way, you understand that is a obstruction to the ventilations or patient is not able to breathe. Nurse and the respiratory therapists jointly are responsible for preventing this condensation build-up. The humidifier is an ideal medium for bacterial growth. That is, you have to always look for the ventilatory alarms. The mechanical ventilator comprise the audible and visual alarm systems which act as immediate warning signals for altered ventilations. The alarm systems can be categorized according to the volume and pressure. The high pressure alarms warns the rising pressure and low pressure alarms warns the disconnection of the ventilatory circuits. The complication of mechanical ventilations are there different types of complications. There is airway complications, mechanical complications, physiological and artificial airway complications. There is the airway complication is aspirations, decreased clearance of secretions and nosocomial or ventilatory associated pneumonia. Mechanical complications is the hypoventilation with atelectasis, respiratory acidosis or hypoxemia, hyperventilation with hypocapnia and respiratory alkalosis, barotrauma, closed pneumothorax, tension pneumothorax, pneumomediastinum and subcutaneous emphysema. And mechanical complication is also the alarm. If your alarm turn off, then there is again mechanical complications. Failure of alarms of ventilators, inadequate nebulization or humidifications or overheated inspired air or resulting into the hyperthermia. Physiological complications are fluid overloaded, decreased cardiac function and hypotension, stress ulcer, paralytic ileus, gastric distension, starvation and desynchronous breathing pattern. Nursing care of the patient on mechanical ventilations. The assessment of the nursing assessment is very important. Nurse is always and look for the patient. She has to assess the patient, assess the artificial airway like tracheostomy or endotracheal tube, or she has to assess the ventilator. Methods of weaning is that when you want to wean the patient from the ventilator, you have to give the trial for this TPS trial, continuous positive airway pressure, that means the CPAP weaning trial or SIMV mode. You have to keep the patient on the SIMV mode, and by gradually you have to decrease the respiratory rate and gradually you have to decrease the tidal volume and FiO2. Pressure support ventilations, weaning. There is a weaning criteria and you have to see that how can you wean the patient from the ventilator. The resolution of significant improvement of the cause which determine the ventilator dependence. You have to treat the cause and then you have to wean the patient from the ventilators. If the patient is hemodynamically stable, then you can wean the patient. If the patient appropriate oxygenation and appropriate neurological status, then you can wean that patient. Preserved ability to protecting airway and removing the secretion, then and then only you can wean the patient from the ventilator or acceptable hemoglobin level is desired. Criteria for satisfying in order to weaning from the trials is successful. How can you decide the patient, you can wean this patient from the ventilator also from the ABG also. Oxygenation you can check by PO2 if more than 60 and SO2 is more than 90. When the patient required FiO2 is less than 40%, then PO to FiO2 ratio is more than 200 and PEEP requirement is less than 5, then you can wean these patients. Again, there is a PO2, PaCO2 by means of ventilation. When increases in the PaCO2 more than 10 mm of Hg or reduction of pH is greater than 0.01 and the systolic pressure is more than 90 and there is a normal pressures. If the patient's adequate pressure is there, then you can wean that patient from the ventilations. If the patient's respiratory rate is adequate, you can then wean the patient from the ventilator. And if the patient is not agitated or not exaggerated, then you have to see that patient, if the patient is not agitated and not exaggerated, then you can wean that patient from the ventilator. These are the some criteria for FiO2 PEEP requirement. When the patient's requirement of FiO2 is 30%, then there is your PEEP at least for 5. And when the according to these ARDS guidelines, so when the patient's oxygenation is not improved, and you have to goal of O2 saturation is 88 to 95%, with the PaO2 is 55 to 80 mm of Hg, then you have to set this FiO2 PEEP ratio. When you increase the FiO2 initially 100%, if the patient oxygenation is not improved, then you have to increase the PEEP, and then according to that, this ratio, if the patient FiO2 requirement is 50%, then your PEEP at least 10, and if the patient FiO2 is requirement of his FiO2 requirement 100%, that your PEEP should be at least 18. Thanks.